we have two types, either the shunt associated acyanotic heart disease or the valvular or obstructive acyanotic heart disease. So from there, we can take it into usual common shunts, like interatrial shunts, interventricular shunts, interarterial shunts, like ASD or VSD or the PDA, which are common, usually well understood by many people. We'll try to go over many aspects, inshallah, that will widen and brighten your views about managing patients with such shunts. The other obstructive lesions like aortic stenosis, mitral stenosis, coarctation, and pulmonary stenosis are the types. وممكن طبعا in later sessions we can talk about the regurgitant lesions like mitral regurg, aortic regurg, pulmonary regurg, and tricuspid regurg. بالمناسبة, I have all of this on the YouTube. All the pathophysiology of all congenital heart disease and lesions, it's all in the YouTube in about, I think, 21 or 22 session in the YouTube in detail explained. هل شاركت هذه الأشياء مع الزملاء أحمد؟
ممكن أشاركها، حاضر أحطها على الجروب إن شاء الله.
أي لو تحطها على الجروب، لأنه في حوالي 22 سيشن يوتيوب محطوطة فيها كل أو أكثر حتى من الكلام اللي أنا حقوله في المحاضرات هذه. طيب
تمام، هحط قناة حضرتك إن شاء الله على الجروب.
ممتاز. أنا ما أضفت إليها شيء من زمان، لكن this was the effort done in the first 6 months of year 2020. طيب, so if we go now, start from the larger thing, the ASD. The ASD is one of the acyanotic congenital heart disease. The pathophysiology of the ASD depends on the size of the defect, for sure, although the size of the defect is not the major deciding factor in the ASD pathophysiology, but the size does matter. Yet it is the compliance of the RV, the right ventricle, and the pulmonary vascular resistance and the tricuspid valve status are also major playing factors in the amount of shunt that we see in the ASD. The ASD can be just a regular ASD or what we call the obligatory ASD. Some cardiac lesions have an ASD that's obligatory, مثلا زي total anomalous pulmonary venous drainage. You have to have an ASD for these patients to survive. That ASD is not the pathophysiology we are talking about today. Talking about the regular ASD, interatrial communication, secundum type, which has no other associated lesions, but we will also add to it. So let's take it from the simple to the harder. If we talk about small ASDs, small meaning an ASD less than or equal to 6 millimeter in diameter, that is a small ASD. Small ASDs usually have no significant pathophysiologic effect because the shunt is usually small, even with the best compliance of the right ventricle, even with the lowest PVR in the pulmonary arteries. As an ASD is usually less important when it is less than or equal to 6 millimeter. Another thing in this ASD is also that when it is less than 6 millimeter, maybe around 3 or 4, usually it is a patent foramen ovale that could be stretched. And we can see that a lot in the newborn. And sometimes we see in the echo report that it is called 5 millimeter ASD. And when you really look at it carefully, you will find it is a stretched PFO. Just the primum septum is away from the secundum in a distance that's about 5 millimeter. That looks like an ASD, but it's actually a patent foramen ovale. So small ASDs do not carry large shunts, and they are not expected to cause any significant hemodynamic effect. But is that all the pathophysiology we can see in small VSDs? No, obviously no. The small VSDs can have other type of pathophysiology not related to the shunt, especially if they were associated with an aneurysm, which is paradoxical embolization. So we may see a pathophysiology of cerebrovascular accidents with ASDs, because especially if they have an aneurysm, because that kind of aneurysm can act like a sac that a clot can develop in, or just the presence of that small ASD can allow a clot to pass from right to left during Valsalva maneuver, during increased interthoracic pressure for whatever reason, and cause a small clot, especially in ladies, to move from the right side to the left side, causing a totally different pathophysiological effect that has nothing to do with hemodynamics, but with CVA-like lesions. So that is another pathophysiology. The presence of an ASD itself, regardless of size, can also be associated with another pathophysiology, which is arrhythmias. When you have a defect in the interatrial septum, you have an inherent tendency that this patient may develop atrial arrhythmias, although it is more common with larger ASDs, but the presence of an ASD makes this patient liable to pathophysiology of supraventricular tachycardia, sick sinus syndrome. Unlikely, if it is small, that this patient may have atrial flutter or atrial fibrillation, but premature atrial contractions, supraventricular tachycardia, sick sinus syndrome, conduction abnormalities like first degree AV block, second degree very unlikely, but first degree. All of these are pathophysiological effects that can happen even in a small ASD, although we do not put a lot of clinical weight on it. That means if you diagnose somebody with a 4 millimeter ASD, you know it will close most likely by itself soon. But you know also that an ASD can be associated with other non-hemodynamic significant effects. Right. Let's go now to the larger ASD. The same applies in terms of the arrhythmia, the paradoxical embolization, although in the larger ASD, the likelihood of paradox is much less because the septum does not have much of a wall. Usually there is not an aneurysm where a clot can form. But all the arrhythmia, especially if the time goes, passes a lot for a long time, and atrial enlargement happens, then you start getting your arrhythmias. So a moderate side ASD, anything between more than 6 millimeter, probably less than 12 or around 12 millimeter, is considered around, let's say 10 to 12, is considered a moderate size ASD in any person. طبعا the smaller the baby, لو كان وزنه والله واحد 1.5 kilos premature with a 10 millimeter ASD, that's a large ASD for that patient. But we're talking in general for the term baby and above. So A moderate ASD can shunt. A moderate ASD can close spontaneously by itself. Anything less than 10 millimeter has a good chance of closure, especially in the first 2 years to 3 years even of life. That's why we do not interfere with smaller ASDs less than 10, unless we're really sure that they are not going to close spontaneously. We allow them to go to reach the age 3, even up to 5 years before deciding whether we want to close or not in any manner, whether it's interventional or surgical. So a moderate size ASD is expected to cause a small to moderate shunt. It is not expected to cause a large shunt. It is expected to cause mild dilatation of the right atrium, the right ventricle, not severe. It is expected, as I said, to close, and we usually allow it to go to 3 to 5 years, then we decide. So, is a moderate ASD associated with heart failure? Can heart failure happen with a moderate ASD? The answer, the typical answer is no. The pathophysiology of heart failure does not occur with a moderate size ASD. But if we leave a moderate size ASD for a long time means not just few years, means few decades. That means 20 years, 30 years, and you leave the right side to dilate significantly and diastolic function becomes a problem, then you may see signs of heart failure for many different reasons, whether it's just the dilatation and loss of function and the tricuspid regurg, whether it is the rarely associated pulmonary hypertension, or whether it is the arrhythmias that can be as complicating such a lesion. So, but again, in terms of symptoms, small and moderate ASDs are usually asymptomatic. And when we say asymptomatic, because they don't do much hemodynamic effect, we mean that the patient usually is not aware of symptoms. Rarely with exercise, or when we test them or put them on the treadmill if they're older, they will discover that actually they have symptoms. Or when you close the ASD and they come back to you, then you'll find out that they tell you, wallahi, my child now has gained better weight, or I found that I'm doing better home activity and extra outside the home in terms of exercise or sport. I feel I am better. So usually they're underdiagnosed with their symptoms. طيب. The large ASD, that means the ASD above 10 or 12 millimeter, is less likely to be closed spontaneously, even if we allow time, but we still allow time because we do not have much hemodynamic effect again. And the severe RA and RV dilatation, usually that doesn't happen except after few years of having that such large ASD. A large ASD is also less likely to give heart failure, although it's large, because the compliance is so good, the function is so good in children, and it takes so many years to lose that and then show the signs and symptoms of arrhythmia, of heart failure. Arrhythmia on the same line is also unlikely in the first few years. We don't see that, but we do see it later on in life. The shunt is usually large. دقيقة واحدة. Also, and will not cause arrhythmias except later on. طيب, when we talk about large ASD, we have to take in consideration few things. A very large ASD can become like a common atrium. And then if it acts like a common atrium, then the incidence of heart failure is higher. The incidence of all type of atrial arrhythmia, including heart block, variable degrees, and the incidence of pulmonary hypertension can be much higher than the ASD, which is large, but not to the extent that it looks like a single atrium or a common atrium. So that is a very important thing. If you see a baby who is a 6-month-old with almost a common atrium, that is not a baby to wait on to repair the ASD. That is a baby that you need to repair the ASD as soon as possible, because all the other risk factors which do not occur hemodynamically or pathophysiologically in other ASDs, they are more seen and more prone to happen in such patients. Plus, you know that if we have a common atrium, there are other associations in the body that can be, and common atrium is not a disease that's usually solitary. It can be part of an incomplete AV canal. It can be part of isomerism. It can be part of syndromes. And that's why we have to differentiate these very large ASDs that look like a common atrium or a common atrium from the usual large ASDs. طيب, we passed by pulmonary hypertension. When would an ASD cause pulmonary hypertension? It is extremely rare to see pulmonary hypertension with an ASD. And if you see pulmonary hypertension significant, I'm not talking about less than 40 millimeter mercury RV pressure. I'm talking about RV pressure of above 50, more like 60 or 70. When we see that in a myth of an ASD, then the disease most likely is not just an ASD. The disease is usually an association between a congenital heart disease, which is the ASD in this way, and primary pulmonary hypertension or other causes of pulmonary hypertension. We know there is something called malignant ASDs. What are malignant ASDs? A malignant ASD, you would go and diagnose a patient, usually with a small or moderate ASD, but you find that the RV is severely hypertrophy, dilated, significant TR, RV pressure is almost like 70, 80, 60, out of proportion. And they go into an accelerated phase of increasing their pulmonary hypertension to the extent that they may develop cor pulmonale-like picture, right-sided failure. This is what we call the malignant ASD. And a pitfall in this diagnosis that physicians may fall into is that they would say, well, this is a 6-month-old or a 4-month-old. The ASD is moderate. He's developing progressively pulmonary hypertension. Let's go and close that ASD. Thinking that the ASD shunt or the presence of the ASD is the cause of pulmonary hypertension. No, actually, this is the reverse. A lot of the time, there's primary pulmonary hypertension in association with this congenital heart disease. And that's why in these patients, cardiac catheterization for calculation of PVR, pulmonary vascular resistance, shunt, and reactivity to vasodilators, pulmonary vasodilators like 100% oxygen or drugs. It is so important before we decide to say, well, this is a 4-month-old, moderate ASD, he's in heart failure, pulmonary hypertension, let's go and close that ASD. No, that's wrong before you do the full study. ASDs can act sometimes in a pathophysiological way like total anomalous pulmonary venous drainage. It is usually a large ASD, and when you do the echo, you'll find that the pulmonary venous flow is actually directed towards the ASD, and actually most of that flow is going to the ASD. And you have to, in that case, you have to have a good echo evaluation. And usually these patients are in bad heart failure early on in life. Early on in life, meaning what age? Meaning 2 weeks up to 8 weeks. And then you will be so puzzled. Why are they in heart failure? It's just an ASD. Be careful. In a rare occasion, you might have an ASD that acts like total anomalous. Go back to your echo images and do a good echo and color Doppler and see what is the pathophysiology going on. Is the flow going half to the mitral, half to the ASD, or is it really a lot directed through the ASD to the right atrium? And in this case, it really can act like total anomalous pulmonary venous drainage and has all the pathophysiology of total anomalous pulmonary venous drainage. Yes. One last thing, that when we talk about ASD pathophysiology, we have to talk about associations with it. A large ASD with right partial anomalous pulmonary venous drainage is a common association. Common association alone, or when the secondum ASD is sinus venosus type, or in like conditions like scimitar syndrome. And those have their own specific pathophysiology. It may mount up to be even like total anomalous. If you have a large ASD plus 2 veins coming to the right atrium, then this is almost total anomalous. And these patients do present in heart failure. These patients do need early intervention if they are in heart failure. We do see sinus venosus ASDs with partial anomalous who are actually okay for a long time, and we defer their repair until they are around 2 to 3 just to get a better repair and not to dehisce the patch after the repair if you do it earlier on. But again, they can act like a total anomalous. If you have a primum ASD, primum ASDs are usually underestimated in size. So we say it's a 5 millimeter, it could be a 7 to 8. Primum ASDs are usually not a benign lesion because they can be associated with mitral cleft, they can be associated with heart blocks and the mitral regurg, and they can be part of a complete AV canal. If they are alone, and they are not associated with any other thing, they will act like an ASD, a regular ASD. If they are in association with like a partial AV canal with a mitral cleft, then they will act like a partial AV canal. السؤال يقول ممكن تاني، معلش أنا ما انتبهت، بس خليني أشوف الشات. Yeah, it is voice only. I'm sorry. Is that causing you a lot of trouble?
ده
أحمد.
تمام. لا الكلام واضح.
بس كده خد نظرة سريعة على الزملاء. Is that
تمام.
causing you a lot of trouble or are you able to follow with me?
يعني في مشكلة بالنسبة للمحاضرة فويس بس. يعني معظم الناس كاتبين هو كويس، بس يعني محتاجة تركيز أكتر بس في الكلام.
تمام. طيب في سؤال يقول ممكن تاني ASD can act like total anomalous pulmonary venous drainage. Need more effort but I can keep up. كويس جدا. Very good. No. Malignant ASD again please. طيب انت بتسجل ولا لا يا احمد؟
بسجل.
طيب تمام عشان في سؤال. طيب I'll tell you what do I mean by total anomalous can act like total. An ASD can act like total anomalous. If the ASD is large and you look at echo, and you will find that the pulmonary venous drainage, all the veins are on the left side, but the flow is directed through the ASD. أحيانا تكون مكان ال ASD, sometimes the place of the ASD is so close posterior to the veins that actually, when the flow comes out of the pulmonary veins, it actually just goes directly into the ASD, and now most of the cardiac output is going back to the right side. And in this case, this is the only way to know this is actually to do a meticulous echo and see how is the flow being divided in the left atrium. Is it all directed to the ASD? This can act like a total anomalous, and these patients can present to you early with heart failure. Malignant ASD, what we mean by malignant ASD is an ASD that usually looks more small, moderate, but then you will find on follow-up that your patient is developing pulmonary hypertension progressively. One simple thinking is that this is because of increased shunt. Pulmonary vascular resistance is going up because of the shunt, and that's why the pulmonary hypertension is developing. This is not usually the story. The story, if you see like a 2-month-old with a 7 millimeter ASD, small to moderate, and then you see him after 2 months, and then you find that the pressure is high in the lungs, it's becoming 60, 70 by TR or by PI, then this is a malignant ASD. But what's the cause? Usually the cause is the presence of primary pulmonary hypertension in association with the congenital heart disease, and this is a known type of pulmonary hypertension. And as I said, we have to differentiate. We don't need to go to closing the ASD completely because it can be dangerous for the patient. Sometimes they need that ASD as a pop-off valve if they have severe pulmonary hypertension. That's why in these patients, we cath them and see what's going on. Is it really a huge shunt causing the pulmonary hypertension, or is it a small to moderate shunt with not matching high PA pressure and resistance, and then we should suspect highly primary pulmonary hypertension. If I say, I think by this, we would have covered the most important parts of pathophysiology of an ASD. I'll just give you a break for 2 minutes. Any hot questions? I'm looking at the chat. Any hot questions? Right. A question says, what happens if you close an ASD with pulmonary hypertension? If it is mild hypertension and the shunt is large and we close it, usually the pulmonary hypertension will resolve. That means an RV pressure less than 50, 40, 38, 35. And you close the ASD, usually this high pressure is just because the shunt is large. So when we go and close it, we document the large shunt. It's only mild pulmonary hypertension. We close it. Usually the pulmonary hypertension resolves. But if you find moderate or severe pulmonary hypertension, you have to document it is a large shunt and the pulmonary vascular resistance is reactive. What do we mean by that? We go and calculate the shunt by cardiac cath, and we calculate the pulmonary vascular resistance in room air. Let's say it comes as 7 Woods units, which is high. And then we give oxygen 100%, and we find it drops to 1.5, and the shunt becomes even larger. This is a very reactive pulmonary pressure, and the cause is most likely the large shunt. We go and close it. But if we document that this patient has severe pulmonary hypertension and not a large shunt, and the reactivity is minimal, we do not close the ASD. If you close the ASD, the patient can go in horrible loss of cardiac output, pulmonary hypertension crisis, right-sided failure. Why? Because an ASD in severe pulmonary hypertension acts like your pop-off valve, البلف بتاع المريض. What happens if the pressure goes high on the right side because of the pulmonary hypertension? The shunt in the ASD will reverse, becomes right to left. That improves the cardiac output, صح, on the expense of some cyanosis, which is fine, that's okay. Like the cardiac output will continue because the right to left shunt will go to the left heart and the left heart will eject it. You'll maintain your cardiac output. Imagine if you close an ASD in a severe pulmonary hypertension, and now the cardiac output is stuck and habas in the right side. How can this patient make a cardiac output? They may die from low cardiac output, pulmonary hypertensive crisis. So an ASD in the face of severe pulmonary hypertension, be very careful before you close it. You have to document large shunt, reactive PVR, and a lot of things before we decide. I hope I answered the question. Another question says, indications of diuretics in ASD, is RV dilatation an indication or not if the baby is asymptomatic? I would say diuretics have no role in the management of ASD unless you have severe dilatation of the right side or signs and symptoms of right-sided failure. Usually, we do not treat the patients. In over 95% of the cases, you do not need to put the patient on diuretics as long as they are asymptomatic and their physical exam does not show any right-sided failure and the echo does not show severe dilatation. Mild to moderate dilatation, which we commonly see in ASDs, are not an indication for using diuretics. طيب. I think we said enough about the ASD. We will move, I don't see any other questions. We will move to the other more common lesion, which is a ventricular septal defect. Ventricular septal defect is, as you all know, a defect in the interventricular septum, either in the muscular area, the perimembranous area, the subarterial outlet, or the inlet part of the heart. All of these are areas, or it could be multiple, obviously. The VSD is a much more complicated pathophysiology. Let's talk about first the simple pathophysiology of an ASD, a VSD, sorry. A small muscular VSD in any part of the muscular septum, small meaning less than 5 millimeters, something like 4, 3, 2, in that range. So a small VSD pathophysiology is usually a benign pathophysiology, meaning there's a very high likelihood, 60, 70% spontaneous closure rate. Usually the shunt is minimal unless the VSDs are multiple, because muscular VSDs can be multiple, but we are talking now about the single one. Usually the shunt is very low and very minimal. The risk of pulmonary hypertension is extremely low. The risk of endocarditis is there, but low. So in a small muscular VSD, usually we do not have much pathophysiology that will be going on, except for the rare possibility of endocarditis, and then we go into an infectious pathophysiology. We know it closes by itself most of the time. We know it's symptomatic. So it's usually in the first 2 years of life, it can be called a developmental lesion, a small VSD. You know that our heart muscles are يعني الكاردياك muscle عبارة عن شبكة وليست parallel fibers. Okay, so these kind of things need to grow more during the first 2 years of life, and then we end up having closure of such smaller VSDs completely. طيب, let's talk about a larger VSD. If you have a VSD from 5 to 7 millimeter in the muscular area, again, if it is more towards 5 millimeter, the shunt is usually small. And when we say small, it means a shunt usually less than 1.8 to 1, more like 1.5, 1.4, a very small shunt that doesn't cause much left-sided dilatation and does not cause pulmonary hypertension and does not cause symptoms. When the moderate VSD is more towards 7 millimeter, above 5, 6, 7, then the shunt can be significant up to 2.5 to 1, when then you would expect some symptoms of increased pulmonary blood flow. So again, even if it's a 5 to 7 millimeter in the muscular septum, usually these VSDs have a good chance to close by themselves or to get much smaller to the extent that they will cause no hemodynamic significance within the first 1 year of life. If they don't close by the first 1 year of life, then after that, the rate of closure becomes very low, maybe 5 or 3% per year. Can a moderate VSD cause heart failure? Yes. If the PVR is low, it can. A small VSD does not cause heart failure unless it is associated with other VSDs or with other cardiac lesions. A moderate can cause, and the lower the PVR, the higher the shunt, and these patients may need diuretic therapy, may need after load reduction. But usually it's a good pathophysiological path because these VSDs also tend to become smaller, and they don't cause much pulmonary hypertension, and they don't cause much heart failure. What are the effects of such a VSD on the right ventricle? Usually none, because it doesn't cause pulmonary hypertension. On the left side, it causes left atrial enlargement and left ventricular enlargement if the shunt is 1.8 to 1 or above. Other than that, usually it does not cause. Here, I want to ask you a question before I proceed. Tell me which chambers, okay, tell me which chambers cause or which chambers dilate in the presence of a large left to right shunt from a VSD. Anybody can answer? Which chamber? There's an answer, the left side. طيب. Another answer I couldn't, does it say RV? There's an answer that says RV. Okay, what else? In the beginning, LV, then later RV. Left atrium and LV, left side, first left side, then right side. طيب. Left and pulmonary veins, left ventricle, left atrium, pulmonary veins, good. Right ventricle. طيب. So let me give you here a pathophysiological understanding of any shunt and that will actually lead you immediately to know which chambers were dilated. The cardiac chamber that will dilate is the cardiac chamber that receives the shunt or the extra volume during diastole. Okay? During diastole. Excellent, Ahmed. So if it receives it during diastole, it can dilate because it's not in the systolic. ما هو منقبض. When the cardiac chamber is in systole, there is no cavity inside to receive. It's ejecting the volume. So let's go and apply it to the ASD. Go back to the ASD now. In the ASD, the shunt is going from left to right, atrium to right atrium, will receive it during its diastole and systole, but the right ventricle will receive all that volume plus the systemic venous during diastole. And that's why the ASD causes right ventricular dilatation. The VSD, when it shunts, the blood goes from the VSD through, sorry, from the LV through the VSD and through the RV, but not filling the RV. RV is already contracted, like the left ventricle. They are all in systole. And most of the shunt occurs in a VSD in systole because the diastolic pressure is usually near or equal in both ventricles. Is that clear? So if it is clear, then let's walk with the shunt. Now the blood is going from the LV through the VSD. The first receiving chamber would be the pulmonary artery. So it wouldn't be surprising in large VSDs, not small, not moderate, in large VSDs to see that the pulmonary artery is actually dilated. Why is it dilated? Because, yalla, why is it dilated? Because it is exposed to the large shunt directly. It receives it directly. لأنه الRV مقفول. It's in, yes, it's receiving more blood. The RV is contracted. It's not receiving anything, so it will not dilate to start with. The pulmonary artery can dilate because it's receiving the blood, and what else is it receiving? The pressure. Excellent. It is receiving the LV pressure, the pressure from the LV for sure. And that's why it tends to dilate, and the wall will actually, the media will hypertrophy. طيب. So that volume now is in the lungs. Where is it going to go? Which chamber after that? The left atrium. Absolutely, not the right atrium, the left atrium. The left atrium will be the first receiving chamber in diastole or in systole? No, in diastole. In diastole, it will receive it in diastole, and that's why you will get the dilatation. It's already receiving the normal pulmonary venous flow plus the shunt added to that. It will dilate. Now the left atrium will contract and give all that large volume to the LV, the left ventricle. The LV will dilate or not? Yes, it will dilate because it is receiving the blood in diastole. So whenever you want to know which chamber is going to dilate, walk with the blood and see in diastole which chamber is going to receive it. You will know, because that's where really the effect and the pathophysiology will be. If you go and follow the blood, you will know. طيب. So now we know that a large VSD with a large shunt can transmit blood and can transmit pressure. And now we can actually deduct more pathophysiological effects from these two. What are these pathophysiological effects that we can deduct? Two things. The session today صح ما في يعني screen ولا sharing ولا أي شيء، لكن هخليه شوية interactive عشان it's not going to be يعني boring for you. وهحط الكاميرا عشان كمان نتشارك صوت وصورة. السلام عليكم ورحمة الله جميعا. طيب, so tell me now, what is going to happen with a large VSD in terms of the lungs? What is the shunt doing in the lung? Can anybody tell me? Anyone can say? Plethora, there's an answer there. Pulmonary hypertension, congestion, pulmonary hypertension, overflow, increased pulmonary blood flow. All these are good answers. Congestion, then vasoconstriction, increased PVR, increased resistance. Right. All of that is good. But let's now take it a little bit deeper into pathophysiology. You talked about it very clearly. We call this pulmonary arteriolar edema. Is it true or not? It is true. And it's important to differentiate pulmonary arteriolar edema from pulmonary venous edema. Pulmonary venous edema is the congestion in the pulmonary veins, usually because of diastolic dysfunction from the left ventricle, with increased end-diastolic pressure, with increased left atrial pressure, increased pulmonary venous pressure, and then the basement membrane. The basement membrane will dilate. The normal pores in the basement membrane will become bigger, and then the leak will happen like in mitral stenosis. Yes, you're sure, for sure. Like you said, like in mitral stenosis. But here it is just high EDP. The mitral is good. High end-diastolic pressure, high left atrial pressure. The venous pressure becomes high in the pulmonary veins. The basement membrane dilates, the pore dilate, and then all the proteins and the fluid will extravasate from the pulmonary veins or venules into the lungs in interstitial area. That's why when you have left ventricular failure or mitral stenosis or severe mitral regurg, the pulmonary edema usually is more difficult to treat because it's interstitial. But when it is congenital heart disease with a large VSD and it's pulmonary arteriolar edema, you'll find if you give the patient the first dose of Lasix, even orally, and you start it at home, they get better because it is pulmonary arteriolar edema, increased pulmonary blood flow. So this increased pulmonary blood flow will stay there in a, now we're talking, by the way, about large VSDs. We're no more talking about small or moderate size. When do we expect the symptoms? Because of the normal pathophysiology. Yalla, if a newborn is born, when do we expect the symptoms? Eight weeks, 3 to 4 weeks. When PVR fall, that's a good answer. After drop of pulmonary pressure, when pulmonary pressure decrease. All of these are good answers. Usually, our PVR after being born is at its lowest when we are 6 weeks old. But a large VSD can be symptomatic as early as the first 10 days of life, even first 2 weeks of life, because the PVR then would not have dropped to 1/5, which is the normal, but would have probably dropped to half or 3/4, and then it is a significant drop still, and then you'll start seeing the significant left to right shunt. So they are usually symptomatic from the start because the large VSD is going to convey a lot of blood. طيب, what's the effect of this huge blood and pressure transmission on the lung? How patients react to that? What is the common reaction? Yalla, I'm hearing. I want answers. Vasoconstriction, this is not the common. Tachypnea is a clinical sign. What else? So usually, how would the patient react? They will react by developing pulmonary arteriolar edema. They will. السؤال تاني انه لو عندنا VSD large, we have a large VSD, now it's 2 weeks and the shunt is starting to get large. How pathophysiologically these patients will react? They will react in 2 ways. Either they will show you the heart failure type pathophysiology. ممتاز دكتورة أسماء. Either where they will show you the heart failure pathophysiology, which is the most common, that they will just go into heart failure, showing all the signs of it, lung plethora, pulmonary arteriolar edema, significant LA and LV dilatation, sometimes to the extent that they would develop mitral regurg because of extensive LV dilatation and mitral valve annular dilatation. Even aortic regurg can happen sometimes because of that. Rarer, much rarer than the mitral regurg. But they usually go into a heart failure, pulmonary arteriolar pathophysiology. Is there another path? في كان واحدة من الإجابات في الشات إنه pulmonary artery pressure won't drop from, I think, Dr. Asma Abdul Hamid. I think this is it. It is a rare thing, but you have to be careful of such patients. Sometimes a large VSD, just by transmitting the pressure, the lungs will read it as severe pressure and immediately will just keep the high PVR by vasoconstriction. So these patients will not go into heart failure. They will be good. These patients will look at you. They are not tachypnic. They are feeding well. They are gaining weight, but they are not the good patients, because these are the patients who can develop the Eisenmenger pathophysiology very early in their pathway. As early as how many months? في أحد عنده إجابة؟ we have a 6 month, 1 year, 8 month. You are not far. I think as early, one could say easily as early as 9 months. And that's why these patients, if you have a patient with a very large VSD, the shunt is still left to right, but they are asymptomatic. And the shunt is non-restrictive. There is no turbulence on color Doppler. Then these patients are actually the risky patients. The patient, even if you close the VSD, may go down the road to develop severe pulmonary hypertension. And that's why these patients will require early VSD closure. And when we say early, early meaning as early as 4 months of age, 4 to 6 months of age, and we do not delay them. We do not do them when they are 8, 9 months old, because the risk of continuing as pulmonary hypertension is quite high. طيب, I think we've talked about the pulmonary hypertension, the large shunt, the pulmonary arterial edema. Let's go back now to the effect on the LV and the LA. Usually, the dilatation of the left atrium, the dilatation of the left ventricle, if the VSD becomes smaller by itself, or the shunt decreases, or we close the VSD, usually these will all remodel and go back to normal size and no more significant dilatation. Even the association of significant mitral valve regurgitation in the face of a very large shunt in a large ASD, usually these mitral regurg will improve tremendously after closing the VSD by just reducing the annular side, the mitral valve annulus size when the shunt has been removed. Occasionally, when the mitral regurg is more than 2+, that means it's moderate to severe. These will not actually recover because we allowed a lot of time for it to dilate. We should have come earlier to close the VSD and not allow the heart to dilate that much, because at that stage, you may need mitral valve repair with the VSD closure. طيب, VSDs are, as we said, not in the same place. If you get a subarterial VSD, it can fool you by measuring it like 6 millimeter, 5, 4, when it's actually much larger than that. So subarterial, especially subpulmonic supracrystal VSDs, when you measure them around 6 or 5 millimeter, they are usually 7 or 8. And that's why you'll see a 5 millimeter VSD, but your patient is in significant heart failure. Then you will know that you are actually underestimating the size of that VSD. VSDs can be associated with many other lesions, but let's talk about, before the lesions, many other pathophysiologies. A VSD can be part of a pathophysiology that involves a left-sided obstruction, whether it is aortic stenosis, coarctation, or subaortic membrane. And in that stage, especially when they are newborns, if you have a newborn with a coarc, severe tight coarctation, and a VSD, they are usually in much, much more heart failure than the same size VSD without a coarc, because obviously the afterload in these patients is increased, isn't it? It is increased because of the obstruction. And so the blood has a better way to go through the VSD to the lungs, and these patients are usually in severe pulmonary edema and severe heart failure, and their response to diuretics is usually not great. They usually need to be ventilated, and these patients need the relief of the obstruction plus decreasing the shunt, whether with a PA band or closure of the VSD at the same time. Can the VSD be or cause a different pathophysiology like subaortic stenosis? Yes. The VSD, sometimes you see a small VSD, and then the patient starts to develop subaortic stenosis. Yes, it can happen. A VSD can be part of the mechanism of forming subaortic stenosis, along with a SAM or a fibromuscular ridge or the mitral valve apparatus. Can the VSD be part of a pathophysiology of left-sided subaortic obstruction and right-sided double chamber RV or subpulmonic stenosis? Yes, it can be. And then the pathophysiology will be different. It will be more of a pulmonary stenosis if it is sub-AS, or it will be part of sub-AS if the obstruction is there. Occasionally, it is a triad. Very rarely, you can see that there is submembrane, a VSD, and double chamber RV. And in that case, the pathophysiology is different. Obviously, the pathophysiology of a VSD in the presence of any other augmenting shunt سامعين الصوت؟
مسموع.
تمام. Obviously, if a VSD is in association with other shunting lesion, even an ASD or a PDA, then usually these patients are or will show severe pulmonary edema, pulmonary arterial edema, and shunt. So you may find that you have a VSD which is like moderate, let's say 6 millimeter or 6 to 7, but there is another 8 millimeter ASD with it, and you find this patient is symptomatic. Yes, so an augmenting extra shunt can make a shunt lesion much more apparent or symptomatic. So a VSD with a PDA, a VSD with an ASD also can give you that. VSDs can create complicating pathophysiology. Apparent VSD can affect the aortic cusp, usually the non-coronary, either by sucking it in or using it as part of them, or involving it in endocarditis, and then you'll have aortic regurg. So aortic regurgitation can be part of a pathophysiology that we do see in small VSDs even, which are closer to the aortic valve. And they can really cause a lot of damage. And we have a criteria for managing such VSDs. Can you all think of other pathophysiology that the VSD can cause or can be associated with? Anyone can tell me? Right coronary prolapse, قلناها, aortic regurg for sure. دكتورة زينب بتقول arrhythmia. Is arrhythmia a common association with a VSD? Usually, no. I would agree with that. But where would be the VSD that will cause a possible arrhythmia? The inlet VSD, for sure. If you have an inlet VSD, then your risk of heart block can be more than any other VSD, for sure, because in the inlet you can have affection of subaortic membrane mentioned before, and so on. طيب ايش تقصد دكتورة أسماء by AVN؟ ما فهمتها؟ AV node. Okay, تمام. So involvement of the AV node in and obviously endocarditis, which is higher risk than with the ASD. طيب, can you think of a VSD in another pathophysiological area or pathway? Obviously, yes, we can, if it is associated with other lesions. A VSD with double aortic, with double chamber, double outlet RV, yes, DORV. A VSD with a TGA, thoracic Bing. A VSD which is remote, multiple VSDs. All these may give you different or additional pathophysiologies. But I hope with talking about what we have talked, we covered the most important part in understanding pathophysiology of a VSD. طيب, I'll leave another 2 minutes for questions about what we have talked about. Swiss cheese, yes. Any questions? The VSD is much more understood usually by everybody. Pathophysiology of an apical VSD, small muscular asymptomatic without LV dilatation or cusp prolapse or DCRV. Should we close it for fear of endocarditis? طيب, نجاوب. If pentology cause you mean, does pentology cause arrhythmia? Is that what you mean? Can you explain subpulmonic VSD? طيب, good. So pathophysiology of an apical VSD, usually apical VSDs are quite small, and usually they tend to close spontaneously much faster than other VSDs. But again, if they are multiple, if they are large, then they are really troublesome VSDs. They can cause significant heart failure. They are usually very difficult to treat in terms of intervention or surgical. We sometimes end up just putting a pulmonary artery band to avoid all such multiple VSDs problem, whether it's a Swiss cheese or it is multiple apical VSDs. We'll go to the other question. Small muscular VSD asymptomatic without anything? No, we don't close small muscular VSDs for endocarditis fear. Endocarditis fear is a rare fear, and it's almost equal to the normal heart endocarditis risk, almost equal to it. So we do not close it. And as I said, it is usually very highly likely to cause by itself. دكتورة حنان بتقول pentology cause arrhythmia. ايش تقصد بpentology here؟ إلى أن تجاوبنا دكتورة حنان ننتقل للسؤال الثاني. Can you explain subpulmonic VSD? Subpulmonic VSD is a VSD which is in the subarterial area, a VSD that is more committed to the pulmonary valve. When we do an echocardiogram, you will see that this VSD is supracrystal, and you will, if you imagine the short axis view, the VSD will be around in the area between 1 to 2 o'clock. If you look at the septum in the short axis view, it will be in the area of 1 to 2 o'clock, just under the pulmonary valve. Usually it is covered by a pulmonary valve cusp. That's why it looks smaller. And usually it is a larger VSD that causes a larger shunt and actually may cause accelerated pulmonary hypertension more than other types of VSDs. طيب, دقيقة. Can we explain? VSDPS, asymptomatic timing of repair. Tetralogy-like, but they are pink and they are asymptomatic. Then you are not in a hurry to repair them early in the first few months of life. you probably want to repair them in the best body weight that your center has excellent results with. If you do good results with body weight of 6 kilo and above, you can repair them at 6 kilos. If you do better when they are around 8 to 10 kilos, then you wait until they are around 1 year of age. But a general answer will be good, that if you do them around 9 months age up to 1 year, that would be a good timing for repair. You do not delay them beyond that, because if they are asymptomatic, then the PS is severe, and you don't want the RV to develop severe pulmonary severe hypertrophy and then end up having significant RVH. When do we start medical therapy? We start medical therapy when there is symptoms of increased pulmonary blood flow, failure to thrive, significant dilatation by echo. So usually the medical therapy start is a clinical diagnosis. It's not just an echocardiogram or a diagnostic decision. طيب. You mean tetralogy plus an ASD? طيب. That's what I thought. But يعني, you mean does pentology cause arrhythmia? No, not by itself, but tetralogy patients in general can have arrhythmia because of their issues with hypertrophy, their issues with pulmonary regurg. An ASD alone can cause also. طيب, does it cause arrhythmia by itself? No. 6 to 12 months is an answer. If having significant symptoms and hemodynamics effect, yes, I agree for starting the medical therapy. طيب. Any other questions before we move to the PDA? احنا بدأنا تقريبا 11 والساعة الآن 12 و11 دقيقة. Maybe we will finalize توقيتنا احنا طبعا. انتوا توقيتكم الآن الساعة 11 و10. Maybe we'll finalize our talk today by talking about the PDA. Any questions before I start? No? طيب. So a PDA is patent ductus arteriosus, as we all know. It is the communication between the aorta and the pulmonary artery, a normal communication in utero, where it takes the blood away from the pulmonary artery and supply the lower part of the body with less oxygenated blood than the upper part through the ascending aorta. And when we are born, it's usually the pathophysiological effect is when the oxygen saturation or oxygen tension goes up in the blood, the smooth muscle in these PDAs will contract and the PDA will close. So what if a PDA remains open? Again, we'll talk about PDA small, PDA moderate, PDA large. Let me ask you a question here just to have you all together and we don't lose each other because of no PowerPoint or because of late time. What is a large PDA in your mind and why? Can anybody answer? What is a large PDA and why? More than, and pulmonary artery end more than 2 millimeter. طيب, that's one answer. Five millimeter is large plus hemodynamic affection. يعني you want to relay size to what is it doing. Compare it to pulmonary artery beside it. يعني مثلا لو قلنا بحجم left pulmonary artery أو بحجم right pulmonary artery, more than half the aorta, that will be an extremely large PDA. According to the baby size, that's a good answer. Diameter and age, yes, that's a very good answer. So a 2 millimeter PDA in a 1 kilo baby is very large for that baby. طيب, have you noticed from your answers that no one crossed 6 millimeter diameter, and we are all talking anything between 2 to 6. Obviously, a PDA which is more than 3.5 millimeter, around 4 to 6, is a large PDA for sure, regardless of body weight or age or whatever. Even an adult with a 6 millimeter PDA it's a large PDA. طيب, do you know why? Why is a PDA when it's يعني طبعا VSD لو كانت 6 مللي نعتبرها متوسطة. Why a 6 millimeter PDA is considered large? مين يقدر يجاوب؟ Direct shunt. طيب. Steal of blood, continuous flow to the lung. وبعدين في كتابة يبدو ما ضبطت. High difference pressure because of difference between pulmonary artery and aorta, pressure systolic, continuous flow, steal of coronaries in diastole. طيب, واضح انكم you know the answer but you're not spelling it directly. خليني اقول لكم. A PDA shunts in which part of the cardiac cycle? يلا مين يجاوب؟ Which part of the cardiac cycle does a PDA shunt? Both, all, تمام. So a PDA, unlike an ASD or a VSD, the shunt is truly throughout. It's systolic and diastolic. Why? Because our aortic pressure is higher than the pulmonary artery pressure in both the cycles. In systole, the PA pressure is 20, the aortic pressure is 80 or 100 or 120, then the difference is so high. The resistance is also higher in the aorta than in the pulmonary. And also in diastole, a newborn diastolic pressure will be around 45, let's say, with a diastolic pressure of 15. So 3 times that pressure. So you will have shunting continuous or double shunting, one in systole and one in diastole. And that's why a 4 millimeter PDA may act like an 8 or a 9 millimeter VSD. And that's why heart failure with larger PDAs is much more common than heart failure with ASD or VSD because of the double shunting. It's systole and diastole. And that's why also pulmonary hypertension is much more common in large PDAs than in large VSDs or large ASDs. If you have a large PDA ongoing for a long time, non-restrictive flow, you can get a lot of heart failure and pulmonary hypertension. A VSD, other than the size, will act in terms of pathophysiology almost like, a PDA in terms of the size, other than the size, will act like a VSD. It's a big left to right shunt. The larger the PDA, the more the shunt. The larger the PDA, the more the transmission of the pressure and the causing of pulmonary hypertension. So in that term, the pathophysiology is not different. The only difference is that the PDA will will give you double shunting, and that's why the smaller PDA can act like the larger VSD. طيب, other pathophysiological effect of a VSD other than the shunt and pulmonary hypertension and maybe causing early Eisenmenger? Anyone can tell me? Huh? Anyone can tell me other effects? Differential cyanosis if there is pulmonary hypertension or ductal-dependent lesion, but this is a different PDA. We're talking about the usual isolated PDA, but you are correct. May cause relative coarctation by its shelf. Well, this is an echo diagnosis, and it's not a coarctation. Since you mentioned it, can it cause pseudo-coarctation? Does anybody know that it can cause pseudo-coarctation if you measure by echo, especially if the PDA was in the lower part of the ASD? Yes, if it is after the isthmus, you're absolutely right. Yes, it can cause pseudo-coarctation because when we do our Doppler, we are measuring it below, and it will give you, because it's sucking the blood from the isthmus without the shelf. The shelf has nothing to do with it. Because it is sucking the blood so fast into the lung, it will cause severe turbulence in the isthmus. And when we use the Doppler and the Bernoulli equation, it will read that this is fast turbulent flow, and you will get a gradient up to 50, and then you will say, wow, there's a PDA and a coarc. In that case, if you look at the isthmus and you find it good size, no posterior shelf, and really you don't see a coarc, then you have to question, is it coarc or pseudo-coarc? You will know by forelimb blood pressure that probably there's no gradient. And if you are absolutely fooled and you cath that patient, you will find that actually there's no gradient. It is just what we would call pseudo-coarctation. A PDA itself, a large one, when it gets a bit smaller, can it cause another pathophysiological finding? Cause pulmonary hypertension for sure. Absolutely. A PDA, when it's large, can cause significant pulmonary hypertension. And that's why do not delay closing a large PDA. You close it late, and then late meaning beyond 9 months of age, beyond 1 year of life, and then you will actually have a big problem. Accelerated pulmonary blood flow, no. PDA never causes acceleration in the pulmonary blood flow. ليش? Because the blood is going from the aorta to the pulmonary artery to the pulmonary vein to the left atrium and back to the aorta. It is not crossing the pulmonary valve. The ones that can give you acceleration across the pulmonary valve is the ASD and sometimes the VSD. So shunts that come below the pulmonary valve, not shunts that causes or come above the pulmonary valve. You are right, LPA origin stenosis, it can be associated. What else? What other pathophysiological effect it can give you? Can give you coarctation of the aorta, true? Yes, it can. If it starts to get smaller and it's smooth muscle slings the aortic isthmus, you may develop or see coarctation after the PDA starts to close. What other effects you will see? Heart failure. Why is heart failure caused by the PDA, by the way? Give me two mechanisms. Okay, give me two mechanisms. Coronary steal has been mentioned quite a few times by you. It is extremely rare, very rare for a PDA to cause coronary steal. It's usually very low in the arch towards the isthmus, and that does not allow it to cause coronary steal. If you have coronary steal, you can have it in truncus arteriosus because the trunk that gives the pulmonary arteries is close to the sinuses. A PDA is extremely rare to cause a steal. Mumtaz, somebody mentioned low cardiac output state. Yes, they can come to you in a very low cardiac output state. That's another pathophysiology. Why? Because the blood is really stolen to the lungs through this large PDA. High output, high heart failure. Excellent. So it is another additional cause, not just the shunt, not just the low cardiac output, but high output heart failure, because this is a hyper dynamic circulation, especially in the larger PDA. So there's an answer from Ahmed Fawzi. Heart failure, increased blood flow, hyperdynamic circulation due to wide pulse pressure. And if it causes low cardiac output, then you really can have all the signs of heart failure because of low cardiac output. If there was severe acidosis, infective endocarditis, usually not a cause of heart failure, but it's another pathophysiology. And then we would call it infective end arteritis, because it's usually originating from the PDA. طيب, I think with that, we would have covered quite well pathophysiology of PDA, VSD, and ASD. What do you think? You want me to continue to aortic stenosis and pulmonary stenosis, or do you want us to stop and come to another session, inshallah? أحمد إيش رأيك؟
بص انا رايي حضرتك نعمل اوبستراكتيف انذر سيشن.
تمام تمام. وارجو انكم، يعني انا اعتذر اول شيء والله انه ما فيش باوربوينت. I know it's important، لكن اعذروني جدا، وان شاء الله يعني انتوا يعني استفدتوا وانا استفدت حقيقه منكم كثير. لكن believe me, go back to the YouTube sessions and there will be much more said into that. inshallah المرة الجاية we'll do the obstructive lesions and we'll go over them، وبعدين نسوي regurgitant lesions of the heart، وإن شاء الله يكون في ذلك الفائدة. وأعتذر منكم مرة أخرى، جزاكم الله خير وبارك الله فيكم جميعا.
ربنا يجزا حضرتك كل خير، يعني محاضرات حضرتك ممتعة جدا. أنا
الله
لسه
يكرمك.
حاسس دلوقتي إن إحنا عندنا أكتر من ساعة ونص، حاسس الوقت بيجري بسرعة مع حضرتك.
الحمد لله الحمد لله، الله يبارك. ولكن والله أنا أعتذر، المفروض يكون في باوربوينت، لكن أعذروني معلش، وربنا ييسر إن شاء الله. الله يتقبل
إن شاء الله بإذن الله.
آمين.
ربنا يكرم حضرتك، ونشوف حضرتك في محاضرة جاية إن شاء الله.
إن شاء الله تعالى. السلام عليكم.
وعليكم السلام ورحمة الله.